Back then. So I want to kind of start off real quick about this opening slide. The disease itself, it's called COVID-19. The virus is actually SARS-CoV-2, so you may see that around. So the viral name, this is the syndrome. I'm going to try to go through my slides quickly because we've got a bunch of things to cover today. You can ask questions we don't. We can kind of move things along. So basically, I want to open besides that. But let me start off by saying this is a rapidly changing situation. It's amazing. Every hour we're getting new information. This isn't something you can go to a journal and look up. There's no guidelines. This is one of the things. Fever is actually a pretty important characteristic of this. 43% of them on admission. About 88, I think about 9% doing hospitalization. That kind of helps us stratify some of these patients here. Cough, 67%. Diarrhea is actually very low. That's a good thing to keep in mind because the problem is that most of these patients, what is that? They have fever, cough, and shortness of breath. That's a ton of people. This virus tends to cause pneumonias. This is not unexpected. But you want to kind of maybe keep in mind that nausea, diarrhea, and report are fairly uncommon to try to stratify some of these patients. Intubation is around 4 to 5 days. Most people get symptoms. Just about everybody has symptoms about 14 or less days. There are a few people that do have symptoms past this, very few. So that's why the 14 days tries to help. That's where this 14 days self-isolation comes from. But most people 4 or 5 days. And yes, you can infect others during the incubation period. We don't know how effective that transmission is. Most viruses, such as the flu, you can transmit it, but it doesn't. You can't transmit it as readily as you can when you have full-blown symptoms. So that's just something to keep in mind. We don't know if that applies to this virus yet. Probably does. On admission, so you got one big thing is since this virus causes pneumonia often, CAT scan is very common to see infiltrates for a lot of ground glass opacity. And these people tend to do worse. Severe cases, only 2.9 did not have any CT changes. About 18% also did not have any non-severe. So a lot of times you do have changes on a CAT scan. And the problem is we can't get CAT scans in everybody, because it's tough to do. And then you have to clean the machine, unless you get between each one, which takes a lot of time. So that's a big problem with this. So it's not like we can just get CAT scans to everybody that comes in. Lymphocytopenia was present at 83%, which I think this is something we may need to keep in mind when trying to figure out who we test, what do we do with these guys. So biggie, GI symptoms low, fever, cough, and shortness of breath is the main ones. Lymphocytopenia and ground glass opacity and CAT scan. But once again, we can't get CAT scans. How often do we get CAT scans in a regular someone comes with pneumonia? Not often. Some epidemiology, this is scary. Got this from Ray yesterday from hospitals, American Hospital Association. Basically, you can see that ICU cases 1 to 2%, hospitalization 5%. That's a lot of people. 4.8 million people on admission, 1.9 ICUs. So, and they were like, oh, the mortality is maybe 1%, which may not be, maybe higher than that. But this is what we concern about. These people taking up beds, taking up PPEs, resources, isolation, hospital getting healthcare workers sick. This number is scary. 480,000 deaths. I think that's saying it's 10 times severe as the flu. It may be worse, may not be. But this number could rise. So there's a lot of people saying, oh yeah, you're healthy, you're young, you don't have that huge chance of getting bad things. That's true. But for a healthcare perspective, these people are in the hospital. They take up beds. These take up beds that people with heart attacks, strokes, cancer, that what we need. So that's a big problem. Transmission, okay. So we hear about this everywhere. Mostly droplets. That means it's generally believed to be about 3 feet, maybe 6 feet. You sneeze, you breathe, it gets on a droplet, and it falls on the floor. Okay? And then, medically speaking, airborne is it kind of floats in the air. You can sneeze, and it kind of floats, and someone else walks past and breathes it in. That's kind of the medical definition. We're not 100% sure it's airborne right now, but we do airborne precautions. That's what the CDC recommends. The WHO is a little more lax on the airborne precautions, but the WHO overall gears the recommendations for resource-poor countries that don't have N95 masks, don't have airborne. So generally speaking, when they make the recommendations, they usually look at more resource-poor countries. But, you know, we may become that, we may run out of N95 masks. So anyway, so right now, we recommend, the CDC recommends gown, glove, N95 mask, face shields. Contact with infected fomites, such as the surface, you see that in the touch your eyes. We don't know how effective this transmission is, but right now, it's definitely something we got to be concerned about. Don't touch your face. If you're touching elevator buttons and door handles, like everyone does, this thing dictating into the dictaphone, your hand may be contaminated. So basically, when it gets in your eyes, ears, and mouth. So that's what we're trying to avoid here: eyes, ears, and mouth. All right. Other coronaviruses have been known to infect animals. We do not know if COVID virus, the SARS-CoV-2 virus, is transmitted this way. But ironically enough, the CDC says if you're self-isolate, you should isolate yourself away from your pets. Just leaving that out there. But this is not known right now to be the source of transmission. All right, so no one has to run out, swab their dogs, or leave the dogs outside. Right now, you know, studies are pending, but it seems to be a little bit more infectious than the flu. Have you heard anything different, John? That's about right. Okay. Risk factors. Okay, so who's this population that does bad? Because you hear on TV, you know, lately you're trying to calm everybody down, saying, oh, you got 0.000% of dying. That's probably not true. But these people that do bad are people equal to or greater than 60 years old. Kidney disease, lung disease, heart disease, and over here they got diabetes. Any sort of chronic medical conditions. And, you know, these are, broken as risk factors. They're not really risk factors we know in guidelines. They're not studied. They're not, there's no odds with it. Like I said, this is all evolving rapidly. So if someone has like high blood pressure that's controlled, some mild heart failure, they're going to do better than someone with uncontrolled heart failure. Yeah. So there's always there's a lot of stuff. There's a lot of clinical judgment that goes into this. But we all know patients that fit in here that's going to do bad. And that's where the mortality is. These are the people that go to the ICU. These are the people that we're here to try to help out. And you know, it's not here, but if someone's immunocompromised, that's an issue. They're probably going to do bad. I don't think the study yet, because not things are studied, but these are the things that have been pointed out. This is the group, especially this age group, 60, 65, is right when the mortality starts really taking off. And obviously most of our patients are already like that. Severity. Okay, so this is the big thing. Right now, case fatality rate is anywhere between 2.3% to 3.6%. That was published by the WHO last week, about a week ago from today. And that's kind of high, but they also did say the population has opinion. This is based on some population testing right now. They're still pending. They got to go out and just take asymptomatic people's blood with IgGs and IgMs to see where we wind up. They've started doing that, and the mortality rates really may be somewhere around here. We don't know yet. This is WHO. This is the most recent one that they come on the other day. And once again, they said big population test opinion. When they did come out, there's one interesting thing they said was that right now it looks like there's actually very few asymptomatic cases, which is good in the sense that maybe it doesn't spread as much as we thought it did before. But that on the flip side, that jacks up our mortality. All right, so here's some different statistics. Okay, some of these statistics do contradict each other a little bit. Mild symptoms, 2-week recovery, 81%. and 14% severe, 3 to 6 weeks, 5% are critical. You know, and then so you hear on TV, well, you know, you kind of get the impression sometimes when you hear on TV, oh, you're either going to get a little cough or you're going to die. And most people are going to get a cough. But there's actually a middle ground that comes to the hospital, as we all know as doctors, and they do go home. And I think we got to sometimes remind some people that they're not invincible. If you're healthy and you're young, you'll probably do fine. But there are some people that do bad. And so there is a middle ground here. This is, you know, these people are in the bed for a while. We'll get to that in a second. Transmission, okay, so this is a hot topic. Who gets it, who doesn't? So the CDC kind of defines close contact is basically about 6 feet for a prolonged period of time, such as, you know, caring for somebody, well, that makes sense, living with somebody, right, healthcare waiting area, waiting room, okay? So waiting room. So you don't need all day to be around somebody. But it's also walking past somebody at the grocery store, you're okay. Unless down here, you get sneezed or coughed on. So this is the brief exposure. So if you get sneezed or coughed on right away, that's considered close contact. Walking past somebody in the street, you're okay. Walking past somebody, if they're wheeling a patient past you that somehow doesn't have a mask on and they breathe on you, you're okay. Now if you're examining them, if you're swabbing them, if you're intubating them, you're not okay, even if it's a brief period. How long is a brief period? We don't know for sure, but this is what they have laid out. But we need to keep this in mind because we're going to probably be walking past these patients, and you're going to hear about people saying, "Oh, my mom, my son went, he saw this kid that had diagnosed with it, and he stood with him in a line or something. And this is going to come out." So, and also you can calm people down because I'm sure your relatives asking y'all. I walked past somebody today. They didn't look well. Or maybe they had stereotyped somebody. Let's throw that out there. All right. Kind of talked about this. Diagnosis. The CDC changed their guidelines up, and it's very vague right now. It's very vague. Before they said, someone that came into the country. Yes, obviously someone comes up from Italy, South Korea, China. That's a problem. But now we've got Washington here, all around. And the symptoms themselves are like, well, what symptoms? Fever's a good one. But fever may not catch everybody. But fever should catch the severe cases. So who do we stress? Well, the CDC says you've got to use your clinical judgment. They just kind of left it out there. So this is a big problem. We had somebody in the ER yesterday. Fortunately, we found out it probably wasn't in. We looked at, Dr. Ferguson here, and took a great travel history and found out they got sick here and not where they went to. But this will come up, I'm sure Roland can attest to this, probably come up tonight, tomorrow. We don't know. We really don't know. Someone with a viral pneumonia. Who do we test? Someone with a viral pneumonia. That's the best we can say right now. They have an elevated procalcitonin level, and for once I think I'm actually encouraging people to get procalcitonin levels. Sorry, Barry. But if it is elevated, remember that which higher it is, more likely to be bacteria. Okay, this tends to have a low procalcitonin level. And lymphopenia, like we said before, lymphopenia. So those are the things, and we're going to have to use our clinical judgment. And then the question is, just because you have COVID-19, they don't need to be admitted, okay? They can be sent home. All right, I'm kind of jumping ahead, but they can be sent home. If they need to be admitted for just regular reasons, hypoxia, sepsis, then they should be. So how do we diagnose them? Okay, so this is kind of vague, and we haven't worked through it, and we're waiting for the CDC to give us some guidance. We can call the Office of Public Health. Right down here, this is the phone number, okay? So if we get somebody we think needs to be tested, how to do it? Well, Quest said, and the president said everyone's going to get tested. Guess what? That's not true. Quest said they were going to go live Monday. Well, they did in 3 states, not here. I heard earlier today that LabCorp is supposed to be helping us out. Well, maybe. We need to talk about that, and that may be something we need to get. But either one of these turnaround times 3 to 4 days. Okay? That's 3 to 4 days. If we miss somebody, that's PPEs we're wasting, the room we're wasting. We don't have a lot of PPEs. So the public health can turn around less than 24 hours. But in order for that to happen, you got to call this number. It has to be approved, and they may not approve it. Yesterday, did they ever return phone calls? No. They said they were returning phone calls. You know, and I don't want to make light of it, but in a lot of ways, we're on our own with this. And that's the kind of the conference call I got earlier today with LCMC. We're kind of on our own. So anyway, that's what we're supposed to do, is call this number and get a swab. I think it's somewhere else, but I'll just go and tell you what we need to do. It's a PCR, oh, it's right here. So right now, it's swab back of your nose, back of the throat, and if you can produce a sputum. I don't know if it's necessary. That's what the Office of Public Health wants right now. I don't know if that's necessary for all this, or this is just them studying it, coordinating, seeing if these tests all line up. I don't know. That's what they want. Obviously, sputum, you know, that's plus or minus. They're not producing anything. But this is what they want. And if they do, if they smile upon you and they do say yes, we'll give you the test. They'll get a carry. We order it as a miscellaneous test. The medium is the stuff we already got in for other virus stuff. So we already have it. We ordered as a miscellaneous test in the computer. And we're supposed to obtain it in a negative pressure room. And then our micro lab, is my understanding, will coordinate it with the public health. When they call us back, they carry, bring to Baton Rouge, and then they'll turn around in a few hours and let us know right away. So obtaining it in a negative air room is kind of interesting, because the Office of Public Health also said a lot of this should be obtained by private in offices. Doctor's offices, keep them out the hospital. How many of y'all have airborne isolation office? A lot of this, like I said, does not jive. Anyway. So back to the symptoms, severe progression. This is interesting, and this is something we need to keep. If we send somebody out who said they're not infected, or because the problem is these are the people that do kind of that. First 7 days, pretty good. They worsen about week 2. You need to tell them that. Just say, if you get worse, you have to call the hospital. You have to call us in the back. You need to talk about it. Okay? So around day 7 is when the admissions really start coming in. These are when people kind of get sick. 51% day 8, and then right around the ICU admission around 10, 11, and then in the ICU here. The average person that's with a severe infection usually is discharged around day 20. The ones that die around day 21. Okay? Roughly 14 days here of a acute care / ICU bed that we don't have. If they survive, they don't survive. That's them, us gowning up, throwing away face masks. It's a whole other discussion. So this will gum up the works. Even if they make it, it gums up the works for all the other patients that come in routine surgeries and heart attacks, strokes, everything else. Treatment, support. Okay, for right now. Avoid steroids. Apparently in China they love steroids, and they found these people do bad. They shed more, and their mortality rate is up. Now, we pretty much limit steroids here for patients that are in severe septic shock. I don't know how that goes with this. If someone is tanking, then I would use some steroids, try to get them out, and get them off the steroids as soon as possible. It seems like China likes to put patients on steroids for most viral illnesses, not necessarily for people that are doing bad with septic shock. So I don't know how to rectify this in my mind, but I would say if someone really needs it, they're doing bad, put them on steroids, pull it off as quickly as possible. We need it as quickly as possible. Remdesivir, this is when you hear about, they're investigating right now, we don't know how well it works. Lopinavir, ritonavir, this is an old HIV med. Actually, we got some patients on this too. This is around everywhere. They don't know if this works either. Apparently, it kind of worked in MERS, so they're testing this out. This would be wonderful if this works. And they're trying a few other HIV meds out because we got plenty of this stuff around. And Arencibia, maybe I'm saying it wrong for your rheumatological people. I think this is for treatment of rheumatoid arthritis and a few other sort of things. Apparently, it's approved in China for treatment of it, and it blocks interleukin 6. There's a cytokine storm that happens toward the end of this, in the severe cases. So, there's no recommendations here. And I imagine this is something really expensive. I don't know. It's a monoclonal antibody. These tend to be very expensive. I don't know yet. I mean, as soon as we get more guidance, we'll be happy to share it. On a side note, I was looking up to about well past midnight because I kept on getting some information on some things last night. I was trying to update this thing. Didn't get it all on here, but some of the patients that do bad, about 50% of them get other infections. So that's something to keep in mind. So antibiotics may play a role in the super infections. But for right now, it's mostly supportive because this is a viral pneumonia. You know, flu probably causes some flu, viral pneumonias, but a lot of people get staph and strep pneumonias and die from that. This is usually a primary coronavirus pneumonia, but then like most patients, when they start getting sick, they get other infections. So I'm going to try to hurry up here. Things on a mission that shows people doing bad. SOFA score. I did a plain talk, so you can look online real quick. It's actually, we have it listed, I think, on our surviving such as PowerPoint with the SOFAs. Higher SOFA scores, worse you do. D-dimer of all things, greater than 1 tends to show people that do bad. I thought that was very interesting. So if you think they have it, probably procalcitonin level, D-dimer, we should probably do D-dimers. In age, we already talked about that. This is the D-dimer. The blue, people that do good. People who don't do bad. These are the people that don't live. You can see the D-dimer, really big, 7, 10, really start going up. So you can kind of stratify who's going to do bad. This is lymphocytes. The survivors can have higher lymphocytes. This is CR. This is high sensitive CRP. Not surprised the guys that do bad that die goes up. And this is lactate. Not surprising too. I mean, you can see it starts off bad and they do really bad, and the ones that survive goes down. But I think D-dimer is important to keep in mind when taking care of these patients. These will let you know who's possibly do bad, and of course the lymphocytes. Oh, when you get people off precautions, we don't know. They're saying 2 negative tests and people are doing bad. Well, we can't test. This is just a vague recommendation right now. So 2 negative tests, well actually 4 tests, 2 from the nose, 2 from the mouth, taking them 24 hours. Clinical improvement. And this is a long thing from the suggested one someone threw out from IDSA that I put likely to change, because they even admit it's likely to change. It's basically, if they do bad, if they do better, it gets negative testing. Oh, this is some websites. This is a very interesting website. This is from Johns Hopkins. If you want to literally see a pandemic unfold, go to this website. It's fascinating. They update it all day long with real-time information. You can click on the country. You take your deaths, how many people recover. You can see graphs, how many people doing better. What's the latest head? It's fascinating. And this is right before we had ours yesterday. We're going to dot now. Other ones, CDC is very good. This is changing day to day. You can go there for information. And if anyone wants to sell, the WHO is they're good. They kind of give a general broad picture. Secretary basically almost every day gives a speech about what he thinks is happening, and that's very good information. I don't know if we want to have time to talk about doctor now. We may need to. What's that?
We'll do that just in time. We're going to have to.
Okay. So I'm going to step away. Jeanne, who's up next? Okay.
Okay. So just to make everyone aware of what processes we have put in place at every point of entry, whether it's an ED, a clinic, outpatient testing, we have these algorithms that the patients are being questioned about a travel history and symptoms. What we're stressing is that even if they don't have a travel history, if they have respiratory symptoms, if they're coughing, we want them masked during their care, okay? So the faster the masking, the better. I'm not going to go into all the details of these. Actually, I have amended some of them since I posted them in this presentation. I've been talking to some of the clinic staff. But all the clinic staff, registration staff, ED will have this information, and we will send out updates as we need to. And with each of these, I have also sent out guidance, so once they get to the point where a notified provider, there's some guidance for you guys. The big thing is, if we don't need them to come in, they don't have to come in, don't let them come in. We need to utilize telephone care as much as possible. Got a phone call from someone in the room today, and she was able to care for the patient over the phone, give them some instructions, what they report back. So keep them out as much as we can. The other thing I want to point out, when I'm asking patients who are symptomatic, but if someone is asymptomatic, but they have traveled to one of the high-risk countries, we also want to mask them. We're not sure if they're shedding. Okay? They may come in, explain to ED triage people, they may come in complaining that they hurt their ankle, but they traveled to Italy. Well, we probably want to mask that person while they're here around our vulnerable population. We have algorithms available through the phone screening at the time of making an appointment or scheduling a test. And then we also provided one for in-person what to do. This is, I'm just going to hand this over to you really, but really, again, we're looking for those respiratory symptoms and epidemiological risk. But what's the definition of epidemiological risk? That's what's going to change from day to day. Currently, right now, the travel hours, and it is really small, Ferguson at the last minute, didn't get a chance to tweak it, but as Dr. DePaula alluded to, China, Iran, South Korea, Italy, and Japan. Of note, Hong Kong is still a level 1 threat and no restrictions. So what do we do if we do have a patient that we suspect? We are going to have to place them in airborne isolation room with contact precautions and eye protection. If an airborne room does not become available, at that point we are going to just put them in some sort of a closed private room. Talk about that. And we are currently, we have PPE, but we're trying to conserve. That's our big thing right now too. Conserving our PPE, so when these patients do come in, we have everything available to protect everyone. Private physicians, I want to bring up, most of you probably have never been fit tested for an N95 mask. We do have plans in place to do just-in-time fit testing to make sure that we have the correct size mask for you at the time. The other thing I want to stress is everything needs to funnel, unfortunately, through myself or Dr. DePaula. I know we talked about how the Office of Public Health, we called yesterday, we never called back. Ended up we didn't need them, but if we did need them direly, I do have a couple of extra numbers, some of their private cell phones if we have to get what we need. So please funnel everything through the source of myself or Dr. DePaula. When in doubt, call one of us.
Alright, so here's the disappointing part. This isn't the zombie apocalypse. You have to sit and watch all your favorite zombie movies. Alright, so real briefly, I did want to just touch on testing. As John said, up until now we've been pretty much guided that OPH was going to provide that. The governor did mention yesterday that they do have several CDC test kits, but as of now I think the count is only about 15 tests that have actually been deployed. The case that we have currently right now is presumed. They still are requiring a confirmatory test from CDC, and I'm not sure if that would happen today or tomorrow. As far as testing is concerned, I think from the conference call that we had today, early this morning, that it seems like LabCorp is going to be our regional provider for the testing. As John said, Quest is not providing that in this area. I did reach out to LabCorp this morning, the rep, and she did send me some guidance that they're basically going to send everybody. So I'm going to ask Ray to see if he can send those PDF guides to everybody's email, which I'll give a plug as well about emails. You've seen us also mention something on Everbridge recently, and if you are not receiving our emails, you really need to let the medical staff office know, especially now, so that you're up to date. So one thing to make sure that you're doing is checking your spam folders if you're not receiving communications from Dr. DeCorte, who's sending one practically about every day right now, if not multiple times a day. Yeah, every third day, there you go. So we'll send you out some information from that standpoint, make sure that you're trying to stay abreast of whatever communications that we send. As far as our clinical offices, you all are our front line. One of the things that we want to do is if you have a suspected case, make sure that you call either Dr. DeCorte or the ER and notify them prior to sending them so that we're a little more prepared. We do have a plan in place as far as how to handle PUIs, persons under investigation. Other than that, oh, one thing I want to stress, both labs have said this, do not send them to any LabCorp site or Quest site because they will not do the test there. They'll turn them away. Probably not a good idea to send them there anyway. One other thing, if you have, I will bring up is if you have medical students or residents that do round with you, we ask that you not have them use PPEs so that we can make sure that we try to keep a good stock of those as well.
Keep them out of the room.
And keep them out of the room, obviously. Yeah. So with that, I think Ray and I will kind of tag team as far as any other recommendations.
We used to just bring up something that you already probably recognize as a conflict. The Department of Public Health, the Office of Public Health is recommending or demanding that these patients be sampled in a negative pressure environment. But they also realize they shouldn't be sent, these walking, ambulatory, relatively healthy patients that need to be tested shouldn't be sent to the emergency department where they're going to really expose some of our most vulnerable patients. And then that they're not going to be doing the swab testing at any diagnostic centers. So unless you have a negative pressure room in your office, where are we supposed to do this? And that's why in some areas of the country you see drive-by testing done. South Korea did it, and I have no doubt that in some form or manner we're going to be doing some type of online registration and drive-by testing. It limits the amount of PPEs that are needed to test large numbers of patients. And which John said, we can't get the diagnostic test right now. The clearance tests, that's going to be down the line to tell whether or not the patients have convalesced adequately. We're not even close to figuring that out. So this will be changing every 3 or 4 days. The PPE issue, for example, is really becoming an issue because our par levels, what our vendors have assigned to us, are based on our annual TB exposure, which is very, very low. And they've cut those levels because of rationing for this as well. So we really have to be careful with our PPEs. And what I might also need some help is, where we can really be the biggest help is with advocating to our patients. Once at some point we start limiting access to various areas of the facility, there'll be some gripes, there'll be some complaints. Please reinforce it's for not just your best interest, but the healthcare team's best interest, so that we're here and we're not having to go on self-quarantine. At some point, I believe that the self-quarantine for healthcare workers is going to go away to the point where if you're exposed, you're going to wear a surgical mask. You're going to work through it. If you get sick, then you can channel for treatments out. That's not out yet, but I have feelings.
Actually, if I can chime in this morning, the CDC actually just said that they're not recommending any healthcare employees to be furloughed. So that means until they have symptoms.
personal protective equipment. The personal protective equipment, the face mask, gloves, face shield, and don't touch my patient.
So, is there going to be
suspected and you're going to have
is there going to be an area in the hospital set up for testing? A separate
That's
area?
what Dr. DeCorte was just mentioning, is that we're already in the consideration phase. We're just kind of, I think we're going to ramp this up based off surge levels. So the problem is right now is we don't have access to testing anyway. And the testing that we have is about 3 to 4 days turnaround time.
John and I spent most of the first few hours of Sunday morning. I thought it was a lot earlier than it was, but I forgot to move my clock, so it was but dealing with the Office of Public Health, having a patient, they literally wanted us to drive up the ramp, do a drive-by swab on the ramp, and let her go, which is malpractice waiting to happen. And our response was, where are you testing? Your Office of Public Health. This should be part of your Department of Health's mission, is to have these clinics available, these testing centers available, in whatever format you needed to do. What are you spending the millions of dollars you're going to do this for? That fell on deaf ears, and it was even more enlightening that they don't have enough staff to do it, and they don't even have adequate personal protective equipment around. So this, what they're not capable of doing has just come to light in the last 4 or 5 days, and we're obviously going to be responding to this on the fly. If it's a relatively small number of patients, we'll do a low-scale testing site. But if it becomes where we're having to screen thousands of patients, hundreds of patients here in East Jefferson, thousands across the regions, we're going to have these drive-through sites set up somehow. Online registration, then drive by, get swabbed, go home, stay masked, and wait for the test result.
So anybody is doing the testing in the city right now? Nobody? None of the hospitals?
They're doing it, but it's not, it's not effective. It's once they've been admitted.
And the person that was being asked to come drive up on the ramp was somebody we had reported to the Office of Public Health a week ago, Monday, as likely because she had come from South Korea 9 days previously and had fever, had a cough, and everything you can possibly imagine. What happened just now with the sneeze from Dr. Another reason that meetings going forward of us will be on a call system. So we're going to try to do a conference call. We commandeered this early, but going forward, if we start having exposures in the community, I think it's time that we say hello to each other on a call.
So, quick question.
Any other questions?
If a person has a URI-like symptom, no exposure to anybody from corona, and they are afebrile, so you don't worry about.
If the recommendation,
if there's no fever.
If they have symptoms similar to that, I would suggest in your clinic setting, because we really don't know if they have it or not, if they're shedding or haven't had full-blown symptoms, that you have them wear a mask. The other thing I've done in my personal practice, and I'll give this as an anecdotal recommendation, is that you start to communicate with your patient base. If they have any respiratory symptoms similar to the ones that are described here, that they try to call in first ahead of time so that we can triage them that way and maybe try to manage them at home for the time being. Unless their symptoms get worse, where at that point then we would notify the ER that we have somebody that's coming in so that we can isolate that patient as well. The reality is the conflicting or difficult part of this is the travel question is really not going to be an effective question to have anymore within a couple days. And we've been saying this since last week that this was going to be a rapid situation. So we're also dealing with flu right now. It's still pretty prevalent. There are some differences between the two, but we can test for flu, and if they're positive for it, then they're not likely going to have coronavirus at the same time. So to answer your question, if you do happen to have a patient in your office that has cold-like symptoms or upper respiratory tract symptoms, then I would have them masked up and try to keep them isolated in an area.
He brings a good point. I forgot to mention they do recommend us getting a flu test. Okay? Yeah, they do recommend us getting a flu test. Now keep in mind, if the flu test is not a PCR, it is probably about 80% sensitive, but as a PCR test, you're looking at more like 99%. So if someone does have symptoms, get the flu test on, especially if they get admitted or thinking about admitting.
Yeah, my office was notified earlier today request labs that if somebody comes in sick, cough, cold, they can turn them away. They can have them go back to the referring doctor to return with the surgical mask before they touch them, take any blood, anything like that. So I don't know if anybody else has seen that. But
Well, we're seeing a few things, and a couple of them are a little distressing. For example, that's questionable point of care. However, there's dialysis centers that said that they're going to screen people that should be patients under investigation. And if they are, and they're scheduled for their dialysis, they're going to try sending you to a local community hospital. I would strongly recommend our nephrologists not do that, because we're not going to treat patients who do not need treatment in our emergency department for various reasons, not the least of which is exposure, and also for even more least than that, the fact we're not going to get paid for it. Raymond?
I have a two-fold question. One is, what is it too early to test? If they have respiratory symptoms, I have the case yesterday talking about. Patient came from Germany 10 days ago, has a worsening cough than her usual cough. It's not horrible. But I didn't want to come into the office, so, we were checking temperatures, and we told her to stay home, we're treating her symptomatically. One of the things is, when did you start seeing the hypoxia? Because we have pulse ox availability, they can buy pulse ox at home, that we can start monitoring patients.
It's variable. It's variable. Usually, maybe around day 6 or 7, unless also anything else different, about a week or so. Yeah, I mean, there's really not much, unfortunately. It's more than just a call, I would say. If they have more shortness, but more pneumonia-like symptoms. If you do, you get evaluated, but once again, there's not a good way to differentiate that from just a regular viral pneumonia.
So now, with the travel history not being necessarily the issue, I'm in your worst case scenario. You have a kid in school who tests positive. What are we going to tell the parents for the rest of the kids? Because you're in that 6-foot window of those kids
that test positive? Well, that's a good question to the Office of Public Health. But I mean, they may want to send the other kids home in self-isolation.
Those are the things we got to think about.
Yeah.
But in reality, in that case, it's likely going to be the teachers and the adults that are going to be positive, and not the kids. I think what's the prevalence of pediatric age?
I mean,
very low.
Yeah, they do very well.
Yeah.
Kids, actually, this is one thing they got going for them. They actually, all age kids, babies and stuff, they tend to do very, very, very well. It's not like the flu, it's kind of like this. This is just low age, mortality goes up as you get older.
So are there worst case scenario contingency plans for surging of ICU beds, staffing? Kind of some horror stories out of Italy, out of, ICU beds.
We have all kind of plans, but like a lot of the first time, when you get punched in the mouth, it's sick. That's what it's coming down to. Are we going to, how many, if you got a surge, need that kind of a surge, how many of your nurses are going to be taken offline? I mean, it's going to be as stressful as Italy, very clearly.
To imagine a type of situation, and people who are, that have been exposed and are well can treat the patients who are sick. If that becomes that scenario.
True.
They got some other things. If you ever had COVID-19, they said you could maybe treat them. We did convert ICU-3 to completely airborne unit. So it's completely airborne. Now you have to walk, even to walk in the unit, you have to be gowned up. To work on the computers, you have to be gowned up. But that's ICU-3 has already been converted and ready to go.
We took that from our Ebola plan back in 2014.
Can you use N95 masks again, or is it one-time use only?
So two points to that. Again, meaning leaving it on all day. Do not take it off. You can take it off, you should not use it again. The second part, which is real important, is how you take it off, and that'll be the doffing and donning. Make sure you take it off from the back. Don't touch the front part of the mask. Do not put your name on it with a marker, because that'll actually make the mask defective as well.
Yeah, the outside is considered contaminated. So
Correct.
You could leave it on. Oddly enough, for TB patients, you can't take it on off because it's not really considered. You don't get TB from fomites. But yeah, you could leave it on for like 8 hours at a time. So we may cohort patients. One nurse or one doctor just gowns up, goes one down, sees all the patients and comes back.
Just to clarify that, you're leaving it on for 8 hours. You will have to leave it on and not.
Right. Oh yeah. I mean, you have a nose. You don't eat. I mean, it could be done.
That's why the contingency plan, it will probably really fall more like Ebola, where we're going to be cycling people in a period of time.
Do we have a plan for reducing hospital visitors primarily because of lack of PPE
We're working on that right now. We're actually going to start in the emergency room, basically enforce what we already have, which is the one visit at a time. But that's a process and evolution. LCMC is already starting to implement this at their facilities where they'll be locking it down to a couple of entry points and screening at those entry points for questions and symptoms. So that's why I have said be prepared for that. My next email is probably going to detail some type of restriction in access.
Regarding DePaula, you put up that slide showing the number of cases that Dr. DeCorte gave.
Yeah.
Is it such a high number because it's just so highly contagious?
So far, yeah. I mean, it's
That's a projection.
That was a projection based on how contagious, correct. I mean, it is more contagious than the flu. It's less than measles, but yeah, it seems fairly contagious right now.
And anecdotal report out of the Boston area, first-hand information was that there were 60 workers who went to a Biogen convention where somebody tested positive. The 60 workers were tested Friday, and the tip that they quickly put up outside of Brigham and Women's Hospital, 26 of them were positive. It was just going to a conference, not an intimate association with a particular individual tested positive.
So compared to the flu, how does that compare?
I mean, I don't have the exact numbers over my head, but it's more infectious than the flu for sure. And keep in mind, the flu, we got Tamiflu to fight it, we got vaccines, things like that. We got nothing. We have no, as far as we know, our antibodies from the other coronaviruses that may be in the room right now do not convey any protection, unlike the flu, sometimes years before exposure, even decades before, can give you some protection about the current strand. So we got, as far as we know, we got nothing to protect us.
Some of those antiretroviral medications.
Is that?
Some of those HIV medications.
But I don't know how the HIV meds. They've tried them. I haven't heard. I've looked and looked. I don't know if I've heard if they're working or not.
That's what they're using right now.
Yeah. Oh, yeah.
We're going to have Roland wrap this up. Here's actually the staff.
What's the length of infectivity once
I don't think we 100% know that. The virus shedding goes for quite some time. The ones that have severe case, they pretty much shed the whole time that they're in the hospital. 14 days, 20 days. So we really don't know quite yet. I mean, if you have a mild case, maybe less than that. These are sort of things I think will come out in the next few weeks as we get more information. That's why everybody has to make sure that we got an up-to-date email. Check your emails, make sure it's not going to spam, because we're going to try to get this information out, maybe do phone calls. I mean, this is very interesting that this just evolves day by day.
I just want to, what's the survival time of the virus on hard surfaces?
You know, that's another good question. At first, they said it was probably a few days. Earlier today, they're thinking maybe a few hours. Now, every surface is different. How much humidity is in the room varies. Maybe days, maybe hours. I don't think we know yet. I would think we should know pretty easily. They could throw some on it and try it out, but apparently this is a hard time.
Is it encapsulated? Is this virus encapsulated?
Yes. Yes, it is. It's an encapsulated RNA virus.
Okay.
Yes, so it may not last as long as
right. Right. I mean, all these household cleaners and stuff.
Are the germicidals effective?
Yeah.
I read something today that chloroquine might be a preventative agent. Any thoughts?
Chloroquine, I didn't come. Maybe I also had ACE inhibitors, maybe too. ARBs. You know, they may bind it. You know, there's a few things out there. I mean, I honestly haven't heard. Like I said, this is constantly evolving, and people are trying. They're hoping to find medicines that we already have that work.
Control what you can control. For example, we all touched those serving utensils. We all touched the forks that are in the thing. So just be careful. You know, control what we control. We're at risk ourselves. So I just scared everyone. It's hand sanitizer in the hallways and use them. As Ray was alluding to, we have MedExec tonight. I'm going to do my best with the agenda not to let that go too far. Because coronavirus is pretty much all-encompassing at this point, and it's all we can talk about. But we got to maintain calm control what we can control. But our medical staff leadership is going to stay on top of this as we have. You'll see frequent emails. Again, check your spam folder, because I was told that a lot of stuff was going to spam. With that being said, I've gotten a lot of questions as we prepare for the vote May 9th about getting materials out. I can tell you the coronavirus is kind of put a little bit of that to the back burner, but very much marketing is working on that. They even have a logo that we're starting to see a little bit, some talking points. I emailed some stuff about that as well. Hopefully get yard signs as soon as possible. I'd like to see if we can get the campaign logo and lapel pins for our medical staff, maybe the magnets that we were having. I still have one on my truck saying we're #1 in the country. Not the country, in the state. We're pretty damn good in the country. So, so hopefully you'll see that coming out as well, because obviously we need all physician support as you continue to talk to your patients and family members and neighbors too. I can't tell you how many people are starting to talk just in neighborhoods about it. So thanks everybody for coming, and appreciate it all. Thanks.